Hello everyone, I'm Ronen Ben-Ami, head of the Department of Infectious Diseases at the Tel Aviv Sourasky Medical Center. It's my pleasure to present a summary of the Global Guideline for the Diagnosis and Management of Candidiasis sections to deal with the general principles of treatment of Candidaemia. There are currently 4 classes of antifungal drugs used as systemic treatment for invasive candidiasis and Candidaemia, each with its specific cellular target and mode of action. They include the triazoles, echinocandins, polyenes, specifically amphotericin B and its lipid formulations, and flucytosine, which is used in conjunction with other antifungals for the treatment of endocarditis and CNS infections. Some important considerations that go into selecting an empirical antifungal regimen include epidemiological factors, so knowing the distribution of Candida species and antifungal susceptibility patterns in your country and in your institution, as well as previous culture results for a given patient. Pharmacokinetics and pharmacodynamics, which can be particularly important for patients at the extremes of age and body weights, patients in intensive care and those receiving dialysis, hemofiltration, or ECMO treatment, efficacy data from clinical trials, and finally, antifungal drug availability, which can vary significantly across geographic regions. To illustrate how variable Candida epidemiology can be, this comparison of European centers shows very significant differences in Candida species distribution among countries and even among medical centers in the same country. Importantly, most of the azole resistance was attributed to Candida glabrata and Candida parapsilosis, and within those species different resistance rates were observed among countries. Candida auris is an emerging drug-resistant Candida species that has become a dominant cause of candidiasis in some countries and hospitals. Candida auris is frequently resistant to fluconazole and other azoles and can acquire resistance to all available antifungal classes. Therefore, the frequency of Candida auris in your institution could have implications for antifungal drug selection and transition to oral treatment. For further information, I encourage you to read the guidelines section on epidemiology. Drug availability can be an important issue. Specifically, echinocandins and liposomal amphotericin B are expensive, and in some countries, these agents may either not be available or access could be severely restricted due to cost. This guideline acknowledges availability issues and provides alternatives for scenarios where first-choice drugs cannot be obtained. The echinocandins are strongly recommended as first-line antifungal drugs for the treatment of invasive candidiasis and Candidaemia, owing to a number of factors. Echinocandins have a broad spectrum of fungicidal activity. Thankfully, even 2 decades after their introduction, resistance is rare among Candida species, although this can be a concern with certain species such as Candida glabrata and Candida auris. They have excellent safety profiles and few significant drug-drug interactions. Available echinocandins include caspofungin, anidulafungin, and micafungin, which are formulated for once-daily infusion, and resafungin, a next-generation echinocandin with an extended half-life allowing once-weekly administration. In controlled clinical trials, echinocandins achieved clinical and microbiological response rates that were similar to those of liposomal amphotericin B, with significantly fewer drug-related adverse events. With respect to azoles, anidulafungin was associated with significantly higher rates of treatment success compared to fluconazole, and azavuconazole did not meet the 15% non-inferiority margin versus caspofungin set in the ACTIVE study, making echinocandins the preferred agents for primary treatment. While echinocandins are drugs of choice for the treatment of invasive candidiasis and Candidaemia, it's important to recognize that liposomal amphotericin B and fluconazole are reasonable alternatives in select situations. Clinical trials performed in the 1990s showed that compared with amphotericin B deoxycholate, fluconazole was associated with similar survival rates and fewer adverse events. However, the activity of fluconazole is compromised by increasing rates of Candida species with acquired or intrinsic resistance to fluconazole, notably Candida auris, Candida parapsilosis, Candida glabrata, and Candida krusei, in some medical facilities. Thus, both liposomal amphotericin B and fluconazole are second-line options for the treatment of invasive candidiasis. Liposomal amphotericin B because of similar efficacy but greater toxicity, and fluconazole because of lower efficacy compared with echinocandins. These drugs might be used in locations where echinocandins are either unavailable or severely limited in availability, in situations where resistance to echinocandins is proven or suspected, for example, breakthrough infection on echinocandin or previous infection with an echinocandin-resistant Candida strain, and infections involving sites with poor echinocandin penetration, such as the eye or the central nervous system. When all therapeutic options are available, echinocandins are the recommended first-line treatment in most clinical scenarios. Blood cultures should be repeated daily until persistently negative, defined as negative cultures for 3 consecutive days. The first of these negative culture days is the date from which the duration of treatment is determined. Persistent candidemia, defined as a positive blood culture for 3 days or longer, should prompt a search for an intravascular focus of infection, such as endocarditis, infected thrombus, or implanted device. Other possible reasons for persistent infection include an undrained abscess, deep-seated infection, or infection with an echinocandin-resistant Candida strain. Second-line or salvage treatment in this situation is based on liposomal amphotericin B, dosed at 3 to 5 milligrams per kilograms daily. If echinocandins are not available, fluconazole, voriconazole, or liposomal amphotericin B represent reasonable alternatives for first-line treatment of candidemia. If liposomal amphotericin B is not available and the patient is refractory or intolerant to echinocandins, the triazoles voriconazole, fluconazole, and isavuconazole represent second-line options, providing the Candida isolate is found to be susceptible to these drugs. Central venous catheters are important risk factors for candidemia, with more than 2/3 of patients having a CVC in place at the time of diagnosis of candidemia. However, determining whether the CVC is a source of candidemia is often difficult. Assessment includes excluding alternative sources of infection and using laboratory markers such as time to blood culture positivity. Candidemia in neutropenic patients is often associated with a GI source of infection rather than the CVC, whereas Candida parapsilosis is strongly associated with line infections due to its propensity to colonize the skin and form biofilm on medical devices. There have been no prospective controlled trials to assess the effect of catheter removal on treatment outcomes. However, observational studies found an association between early catheter removal, i.e. within 2 days of diagnosis, and lower 30-day mortality rates. Therefore, the guideline strongly recommends removing or replacing vascular catheters in candidemic patients as early as possible, ideally within 2 to 3 days. The duration of treatment of patients with candidemia must consider several factors, including the source of bloodstream infection, the extent of deep organ involvement, the presence of endovascular infection, source control, timing of Candida's clearance from the bloodstream, and the immune status of the patient. A minimum duration of 14 days from the time of blood culture sterilization has been advocated. This treatment scheme was used in a 1994 study and has been followed ever since. However, later studies found no correlation between treatment duration and overall mortality or relapse rate among patients with no deep-seated or metastatic infection at baseline. This guideline maintains the recommendation for 14 days of treatment from the first date of blood culture sterilization, recognizing that this is an area that requires additional studies to define the optimal treatment duration in different scenarios. Although first-line treatment of candidemia with an echinocandin is strongly supported by randomized controlled trial data, the required duration of echinocandin treatment is unclear. Switching to an azole simplifies patient management by allowing oral treatment and may facilitate early discharge, reduce the use of vascular catheters, and lower treatment costs. In observational studies, switching to oral fluconazole after 5 days or more of echinocandin treatment appears safe when certain prerequisites are met. Specifically, the patient is hemodynamically stable, blood cultures are negative, the patient is not neutropenic, adequate source control, such as intravascular catheter removal, has been achieved, the patient tolerates oral treatment, and susceptibility to azoles has been confirmed. So with this, I would like to end by thanking the many experts who have contributed to the writing of this guideline, and especially to Oliver Cornely and Rosanne Sprute for their guidance and leadership. I hope this document will help you to manage your patients with Candida infections, and that it will promote research to address remaining unanswered questions in this field. Thank you for tuning in, and goodbye.